At the end of 2013, Western Africa faced one of the worst outbreaks of Ebola in history. Without a vaccine or cure, 11,310 deaths were reported in Guinea, Liberia, and Sierra Leone alone, the three most impacted countries by the epidemic. While the outbreak officially ended January 14th in 2016, the impacts of Ebola left the countries weakened, and it serves as a lesson to why strong health systems are a necessity for global well-being.
Started with an index case of a young boy from Guinea in December of 2013. According to the World Health Organization, the first patients identified in Guinea presented with sudden fever onset, followed by flu-like symptoms of extreme fatigue, muscle aches, sore throat, and headache. These symptoms were then followed by vomiting, diarrhea, rash with small bumps that cover the skin, and external bleeding, such as oozing gums and bleeding skin. Upon further diagnostic investigation, patients also had low white blood cell and platelet counts, and elevated liver enzymes which indicated internal bleeding and impaired liver and kidney function.
Because the symptoms of the Ebola virus, such as headache and fatigue, are similar to both influenza and malaria, the disease was often misdiagnosed, which furthered the spread of the disease and increased the fatality rate. Ebola's later symptoms also often led to misdiagnosis because so many of them are very generalized and similar to the symptoms of Lassa virus and Marburg virus. To achieve the most accurate diagnosis, confirmatory specimen testing is needed. However, blood testing was often not feasible to further confirm individual diagnoses due to inadequate hospital and laboratory conditions. Because the Ebola virus is extremely contagious and has such a high case fatality rate, the case definition needed to be broad to ensure that the spread of the disease was contained. The case definition most commonly used by medical professionals during the epidemic was by the World Health Organization. This case definition was able to be easily used in community health settings, which had limited diagnostic resources and were located in areas of high incidence. The World Health Organization defined the definition of Ebola as any person alive or dead who has or had sudden onset of high fever and contact with suspected, probable, or confirmed Ebola case patient or dead or sick animal. Any person with sudden onset of high fever and above 3 of the following signs and symptoms: headache, generalized or articular pain, intense fatigue, nausea, vomiting, loss of appetite, diarrhea, abdominal pain, difficulty swallowing, difficulty breathing, hiccups, and miscarriage. A person with unexplained bleeding or sudden explained death.
Ebola virus disease is a severe acute viral illness belonging to the viral family Filoviridae within the genus Ebola virus. There are 5 subtypes of Ebola virus: Bundibugyo, Zaire, Sudan, Thai Forest, and Reston, each named after the towns and countries in which they were found, and each, with the exception of Reston Ebola virus, highly pathogenic in human hosts. Zaire Ebola virus has proven to be the culprit of the latest outbreak in West Africa, with more than 28,600 cases under its belt and 11,310 deaths across Guinea, Liberia, and Sierra Leone. It is the most virulent species of the 4 viral subtypes, and, with a case fatality of up to 90%, the most deadly. Ebola can have an incubation period of anywhere from 2 to 21 days, and only becomes contagious when an infected person begins to show symptoms. In the clinical stage of the virus, the pathogen produces flu-like symptoms in the body, which do not typically lead to mortality. As the virus multiplies, it can cause internal bleeding of vital organs and can lead to irreversible and fatal damage of blood vessels and tissues. At this stage of illness, the virus becomes exponentially more difficult to treat, and death becomes likely, making it crucial to receive treatment at the onset of symptoms. Scientists believe that the natural reservoir of Ebola lies in the fruit bat. Fruit bats have been found to harbor viral RNA indicative of Ebola, enabling them to spread the virus to primates and humans through contact with bodily fluids. The transmission of a disease from animal to human is called a spillover event, and the index case of the latest outbreak is a perfect example of this phenomenon. The first patient may have come into direct contact with the bats or with their droppings, or he may have been exposed to those of an infected animal. The preparation of bushmeat provides an additional direct pathway of entry into the virus into humans. However, when it is cooked at more than 121 degrees Celsius, the virus cannot survive. The virus also cannot survive at temperatures below 4 degrees Celsius. Like all viruses, Ebola cannot live without a host. The virus can enter the body through broken skin or mucous membranes in the eyes, nose, or mouth. From there, the virus persists and multiplies in the host bodily fluids and can be spread to others through contact with the host's saliva, breast milk, blood, semen, sweat, tears, snot, or urine. Ebola can also live for several hours on surfaces, such as on doorknobs or tables, allowing it to spread quickly from one person to the next. As seen in the latest outbreak, the most effective method of human-to-human transmission has been through unsanitary burial methods in which mourners are exposed to the virus through contact with deceased victims. This mode of transmission reveals that Ebola can survive both inside and outside of the body for up to a week after death. Even after survival of Ebola, studies have shown that the virus may live for several months in the interior of the eyes, testes, and central nervous systems of recovering patients. With all these characteristics in mind, people who have recently attended the funeral services of an Ebola victim, people living in close proximity to an infected person, healthcare providers, immunocompromised people, recent travelers to West Africa, and possibly even recent survivors of Ebola are all at risk of contracting or spreading the virus.
The Ebola agent spreading throughout West Africa may be attributed to infrastructural, cultural, and social determinants. These issues have arose throughout the impoverished rural nations and perpetuated the increased incidence rates of the disease leading to the 2013 epidemic. Not only are some of the countries affected among the poorest in the world, such as Guinea, Liberia, and Sierra Leone, many were still suffering from broken public health infrastructure left after civil war. These war-torn regions also raised an adult population with little to no health education, which proved to be a detriment when focusing on the safety of cultural practices. Poverty rates and the quality of healthcare provided have a direct positive association, so as many of these African countries are among the poorest globally, there's a clear social indication that disease is more likely to appear. The poor nutrition environment from poverty makes vulnerable the population to infective illness. A susceptible host causes the likelihood of disease to increase. As well, the systems of infrastructure in place, such as road systems, transportation services, and telecommunications, were weak. Therefore, there were several health repercussions noticeable during the outbreak. Firstly, the lack of vehicles and connecting roads from remote villages to central hospitals made difficult the transportation of the sick to treatment facilities, or even made difficult the sending of laboratory cultures to testing facilities, which made diagnosis nearly impossible. A weak system of communication as well delayed reporting of the disease, which caused the spread when considering travel. In the modern era, West Africa has a highly mobile population because of the high number of impoverished persons looking for work or food, and thusly, the spread of the disease through borders had a high and unregulated possibility. Outbreak responders have a difficult time crossing borders, and also, reporting and definitions of disease may not be unified over the countries, making outbreak trafficking difficult. Moreover, many of the disease follow the tradition of returning to their home village for death. This may cause the spread of Ebola to a village that was originally clear of it. The cultural practices associated with death in West African countries accounted for the high risk of transmission. For instance, washing in the water with the corpses or which the corpses were washed in is a singular practice which increased the incidence of Ebola, as corpses are still highly infective. The negative results of these cultural practices may have been curbed with the help of health education. Hygienic practices, such as basic hand washing after touching a corpse, may have prevented the widespread epidemic. However, due to the poverty that plagued the area, it was clear that necessary education was not received. Poverty not only had an effect on educational attainment, but also in the sanitation that may not have a solid implementation in these rural communities. Ebola is spread through bodily fluids, and therefore, without proper irrigation, toilets, and private baths, the likelihood for transmission skyrockets. Ultimately, the determinants of disease for Ebola were mainly associated with poverty, infrastructural inadequacies, and cultural practices, which did not take into consideration the high infectivity of corpses, which contain the Ebola virus. Therefore, in order to curtail epidemics in the future, it would be highly recommended to implement an educational program on proper health practices when in contact with the dead, proper transportation and communication systems, and interventions on the wealth disparity evident in these West African countries.
Developing prevention measures is crucial to avoid the spreading of Ebola across the globe. Therefore, as part of these primary preventions, in some African countries, borders were closed and international traveling stopped, preventing people to travel from countries where there were many cases of Ebola. Also, a crucial part of primary prevention includes education, which has the objective of informing the public and communities about Ebola, how it spreads, the symptoms, and what to do to try to avoid contracting the virus, or how to take action if these symptoms begin. Reducing the risk of wildlife to human transmission from contact with infected fruit bats, monkeys, or apes, and the consumption of their raw meat is also a very important measure. Animals should be handled with gloves and other appropriate protective clothing, and animal products such as blood and meat should be thoroughly cooked before consumption. In addition, to reduce the risk of human-to-human transmission, people should wear protective gear when working with Ebola patients and avoid direct or close contact with them, particularly with their bodily fluids. Gloves and appropriate personal protective equipment should be worn when taking care of sick patients both at the hospital and at home. Also, regular hand washing is required after visiting patients in the hospital as well as after taking care of patients at home. Secondary prevention measures involve those who have already contracted the disease but show no symptoms of it yet. In order to prevent the disease from worsening and spreading to others, we must make sure people with the virus are diagnosed early to increase their chances of survival. Quarantine is used to prevent the infected individual from spreading the virus to others. Individuals with suspected or confirmed Ebola virus disease need to be isolated and excluded from childcare, preschool, school, and work until cleared to return by a doctor, and laboratory tests of blood and tissue should be done for early diagnosis and treatment. Through tertiary prevention, we work with people who have the virus to prolong their life and cure them from Ebola. This would involve treating the symptoms and increasing their quality of life by providing fluids and electrolytes through infusion into the vein, offering oxygen therapy to maintain oxygen status, using medication to support blood pressure, reduce vomiting and diarrhea, and to manage fever and pain, treating other infections if they happen to occur, or performing blood transfusions. In addition, males who have had the Ebola virus disease should use a condom when engaging in sexual intercourse for at least several months after recovery and until advised otherwise by a doctor. This measure could be considered as primary, considering that it is applied to prevent the spread of the disease within healthy people.
The Ebola outbreak of 2013 to 2016 was one of the worst epidemics in recent history. Since the disease was unexpected at this time and extremely contagious, it quickly spread to surrounding areas and countries.
Shown in the WHO map here, the index case was in a small village on the border of Guinea and Liberia. Then the disease quickly spread to larger cities. Some healthcare workers that ended up contracting the disease or travelers that contracted the disease were then sent back to their home to get better care. A few cases were brought back to the United States for treatment, but started a worldwide fear of pandemic. This graph from the CDC shows the epidemiological curve of the Ebola outbreak in Guinea, Sierra Leone, and Liberia, the three most affected countries by this outbreak. There was a huge outbreak and increase in number of new cases or case incidents, with a peak of around 3,550 cases in November of 2014. It is a common source outbreak shown by the shape of the graph. A total of 28,616 cases of Ebola and 11,310 deaths were reported in Guinea, Liberia, and Sierra Leone. Ebola has a very high average case fatality rate, around 50%. Also, it has ranged from 25% to 90% for outbreaks in other specific areas, according to the WHO. The accurate attack rate and data for the Ebola outbreak is difficult to find because of a lack of infrastructure for accurate disease surveillance and the fact that many people had the disease but were not officially lab tested for it. However, people with similar symptoms were also taken into account in some age-specific attack rates. According to a journal named Emerging Infectious Diseases in Sierra Leone, 48% of 937 people had Ebola, and 53% of the 448 who contracted the disease died. According to the figure from the journal Emerging Infectious Diseases, risk for Ebola and Ebola-affected households of Carrington Ebola Treatment Center survivors by age in Sierra Leone in 2014 to 2015 were higher for children younger than 5 years old at around 46% and 38%, and also higher for adults around 30 to 49 years old at around 68% and 71%. Exposure-specific and age-specific attack rates were actually lower for ages 5 to 19 at around 32% and 42% when compared to other age groups. According to this research, there is a strong relationship between household size and high attack rates. Also, the highest risks correlate with exposure to dead bodies, as shown in this figure, and being a healthcare worker.
Ultimately, while the 2013 West African Ebola epidemic was evidently the worst outbreak of Ebola in modern history, there were many valuable lessons learned from it. The results from the epidemiological data made clear that the social determinants of the disease need risk-specific targeted prevention methods to curb the attack rates and incidence. Implementing proper systems of reporting and communication are integral to global health security as well. Therefore, although Ebola still plagues our world, with an ongoing epidemic currently in the Congo, the strides made in global health can be shown through the epidemiologic case study of Ebola in West Africa.